So managing the itchy patient, and I've been itching to have Matt Zirwas tell me, what should I do, Matt? This spot right here is always itching me, so it feels good now. But then when I stop, it's still itchy. So what should I do?
First, Jim, you need to find some friends and use the "you scratch my back, I'll scratch yours" phenomenon. All right. So
right.
Here, let me do that now.
Right.
See,
I could
see,
do
and that
those,
it worked.
But then when you stop
I know now
scratching,
you're
the
done.
problem's still there.
So it is. I just talked about this in my lecture. That there is this new product out there called Dermaleave that works via strontium. So strontium, something most derms have never heard of. I had never heard of it until this product came out. When anything new comes out, I'm always a little like, man, nothing. But I'll try anything. Started trying this stuff in some of my patients with neuropathic pruritus. So you're not quite notalgia paresthetica because you're not normal with anything. Right. But notalgia paresthetica, brachioradial pruritus, scalp itch, groin itch, this stuff is unbelievable. Works in 5 minutes, lasts for about 5 hours. So I do have to tell people you're probably gonna have to put it on several times a day, but it works in 5 minutes. And it is the most reliably effective thing I've ever found as a topical treatment for itch.
Actually, based on that, I've actually tried it, and I found it myself to be very effective. And in our practice, we're starting to use it, and we're seeing the same thing.
Yeah, right? And prior to it, it drove me nuts because things that I thought I should be able to treat topically, so relatively local itch, brachioradial pruritus, notalgia paresthetica, I'm going to systemic drugs. I'm going to mirtazapine and butorphanol, gabapentin, things that have potential for systemic side effects, which would work, but I always felt like I should be able to do this topically.
And sometimes they don't help the itch either.
Yeah, so they don't always work, yes.
Sometimes they don't.
Sometimes they work, sometimes they don't. A lot of side effects, though.
So what about concern about having an underlying systemic disease?
So now I am going to caveat this a little bit by saying, by the time a patient gets to me, I only take patients referred by other derms and allergists, so they've been worked up well. So to me, finding an underlying cause for generalized itch is just incredibly rare. When I do, it's usually in the history, right? They have diabetes, they have known kidney disease, they have known hepatic disease. I can't think of the last time I diagnosed.
That you picked up.
Right, that it was undiagnosed. I did labs because they were itchy and I found it.
I found hypothyroidism.
Yes. Nope, that happens so now, but it might be referral bias. It might be that those patients don't get to me because derms are smart people. It's not like somebody walks in itchy and they're like, I don't know anything about itch. I'm saying they've done a great job before the people get to me. So it might just be referral bias.
So what about lymphoproliferative disease or biliary tract?
Yes, so those are the two things that have been shown. The only types of cancer, because when I was a resident, there was a lot of what itch could be perineoplastic, and then you did a full body CT scan, really good population data. Somebody itchy could have cancer, but with two exceptions, they're no more likely to have cancer than anybody else. Bile duct, and if they have bile duct cancer, they only get itchy after they've had bile backup. So they're gonna be jaundiced, that's gonna be obvious. Right. Or hematologic malignancy, lymph node exam, CBC, maybe a chest X-ray. Simple. You don't need to go fishing for. Do they have laryngeal carcinoma? Do they have colon cancer? And sure they could, but on a statistical level, no more likely to have cancer other than those two.
Very important to know.
Yep.
All right. I'll be sending all the patients your way. Thanks a lot.
Can't wait.
Okay.